always start out by telling your child what to expect. And this might be a good opportunity if you're going to a clinic to call the front desk and ask them, what does an assessment usually look like? Maybe you can even talk to the speech therapist for a few moments and she can help you, or he can help you prepare your child.
When it comes to evaluating for CAS and supporting your child beforehand and preparing them, it's best to talk with the therapist that you are going to be doing the evaluation with. Sometimes I myself will send home instructions for videos that I want to get beforehand, so that way I can get a baseline first. And then that child is also maybe familiar with some of the pictures that we might use, some of the materials that we might use, and some of the things that I might be asking of them.
But usually just telling them we're going to go to this place, there's going to be toys, we're going to have a lot of fun. You can use speech therapist, sometimes we use speech teacher, whatever verbiage is going to make the most sense to your child, and just let them know that this person is going to be listening to how they talk, and that this is a great opportunity also to have that conversation about, how sometimes your words get stuck or it might be kind of hard. Well, this person is going to help us understand why. And then let them know that they might be asked to try hard things and all they have to do is try. It doesn't have to be right. This is not a time where we're wanting them to get it exactly right. I always tell them in the session, hey, I want to see how you try. Let's just see what your mouth does. It doesn't have to sound like mine. I just want to see what happens when you try it. My job is to then help your mouth. And we build this teamwork. So telling them that we're going to have somebody new on our team and we're going to work together and it'll be fun.
So when you're getting ready to go to an evaluation, the SLP might ask you to bring these things, but I would recommend bringing some videos of your child speaking at home, so that if the SLP isn't able to get a good picture of what your child is doing, that they can see that.
And if your child is one that's typically shy or might have lower vocabulary at the time of the assessment, always bring in a video. That helps a ton for the speech therapist to see what's actually happening in the home, because we know we're not going to see your true child in that first session. It takes time to build that relationship. So bring us the videos. A, we love to see what your child's like, and B, it helps us with the assessment.
I would also bring a snack so that the SLP can see how your child eats and how they're using those their mouth to chew food, and see if there's any problems there that might relate to the motor, the speech plan, the motor planning of their mouth. And I think it would also be a good idea to bring maybe a favorite book or toy to help your child transition in, because they are going to be doing hard work.
So if we have a really young child, maybe you're going to maybe your therapist wants you to bring, something at home that really gets you talking, gets that child talking, even if there's only a few things that they're saying. That's where the family is hearing the most speech at home. That might be beneficial for you to bring into the clinic. A child who is older is probably already familiar with speech therapy, but maybe they're not as familiar with doing as extensive, speech testing for that differential diagnosis. And so you can just set your child up for kind of, these are the things that you're going to expect to happen today. This is what we're going to do afterwards. I feel like kind of having, like, we'll go to the park afterwards, or we'll go do something special is also really nice, because they know that they're going to do their best hard work, and then they're going to go and rejoice with their family afterwards.
It's really important too to bring patience and a positive attitude for your child, because you're going to be their comfort there while they're doing some hard work and being asked to do things that are hard for them.
When we're assessing children who are younger or minimally verbal, it's important that they have the ability to attend, that they can have joint attention, that they can imitate. They don't need to have a lot of consonants and vowels in their repertoire for us to be able to assess for childhood apraxia of speech.
So saying childhood apraxia of speech can be super challenging when we're working with children who are just not yet quite producing a lot of verbal speech, who are in their pre-verbal or early verbal stages. When I meet a child who is in this zone of speech and language development, my evaluation is going to involve a lot of time to get them comfortable in the room with me, sometimes even more than one session to do that. And as I let them get comfortable, I'm going to explore their interests and see what motivates them so that I can find a way to get them engaged in imitation. Even if your child is not yet ready to imitate whole words, whole sentences and phrases, or even a little bit of speech sound, hopefully we can find a way to get them involved in some kind of motor imitation. That's going to be my goal with an early motor speech evaluation with a pre-verbal child or an early verbal child, is to get some imitation of some kind, hopefully using the mouth and the oral structures. But if not, other kinds of imitation are great too. That's going to give me information about how their motor system is learning to function and copy in response to a model. And as much as I can, I'll work towards that early motor verbal imitation and those early kinds of speech sound movements and movement combinations. So oftentimes it's going to be an imitation-based evaluation, and how much imitation we do is going to depend on what that child is ready for at that moment.
So if the child is a little bit shy, I'll start with parent interview, where we're going through and looking at the child's developmental milestones, seeing if we see any indicators that might indicate apraxia in their developmental history.
Young and minimally verbal children, their assessments typically have a little bit of warm-up time, some play based in, let's kind of see what's coming out naturally. And then there will be dynamic assessments. So I will tell your child to try a word, and then I will give them some cueing to see if we can improve it. And then I'm going to see, can you maintain that improvement after I stop my cueing? So there will be a lot of, it almost looks like therapy, honestly. I'm just kind of doing short bursts of therapy to see what your child can do. If they are minimally verbal, we're going to stick to simpler words. I might even see if they can imitate some silly sounds. So we might do some animal sounds or some car sounds just to see if we can get that mouth moving. And there will be a lot of the therapist kind of trying to push and then backing off just to make sure that they're keeping your child confident and content in the session and not ruining what this experience could look like.
Also definitely want to get their spontaneous speech and language sample. So do some play and see how they're communicating. If they're using an AAC system or nonverbal communication, things like eye contact, things like that, any speech they can produce.
So one thing that we do is for the little ones, we may just do a play-based activity and just have them just kind of talk with us as much as they can. In that, we're looking to see what characteristics of childhood apraxia of speech are you exhibiting.
They're also going to want to do an oral mech exam to look inside your child's mouth and just make sure that all the parts of the mouth are working in order to be able to produce speech.
And then also trying to do a little bit of an informal oral mechanism exam. So maybe watching the child eat a snack, maybe blowing some bubbles, doing some other things so that we can see how the child's using their mouth when they're not producing speech.
We're looking for oral facial exams. We're making sure that there's no weakness in the face. We also want to be able to do a non-speech oral motor evaluation. And this is important. We're looking, can your child round their lips for blowing or kissing? Can they open and close their jaw? All of these things deal with movement, but we're taking away the element of speech. Then we start to do some other things like what is called rapid syllable rates. We're getting them to go pa, 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 or pa, pa, ta, ka. We're just looking at different syllable structures that we can do with them to see, are we getting different vowel errors? Are we able to do this with ease? We're looking at their rate of speech. Other things that we can do with them is doing different types of assessments. If they have a little bit more language in them, we can do some syllable tests where we're looking to say, okay, were you able to hold the structure of the syllable, or were there breakdowns? We're looking to make sure that they have the right prosody, the right stress, right intonation. Another thing that we can do is even some of these little ones, you'd be surprised that they can do a polysyllable word test. And we're looking to see, are they breaking apart syllables? Are they adding the right stresses on?
It's overall a lot of play, but the elicitation is going to be worked into the play, so you're still seeing the clinician elicit targets more than one time, looking at consistency, adding in some multisensory cueing. That's the dynamic part.
Because therapy is going to take a little while. And so we want to make sure that going to therapy is a positive experience. So sometimes with our little ones, we start off with an assessment and we don't get to do the full assessment until we've done some therapy also. We do just ongoing assessment, diagnostic therapy, basically, to make sure we have the right diagnosis and to see what those skills are as your child gets a little bit more comfortable.
So when children are getting a little older and they have more speech and communication under their belt, this is a great opportunity for us to get into a lot of varied speech acts in the motor speech evaluation. And so I want to see a child communicate in many different contexts. Sometimes I'll ask them to imitate what I say. Sometimes I'll be engaging them in a conversation. I might be having them say very specific words in response to pictures I show them, having them produce some phrases like they're having a conversation, but where I give them some guidance on what to say. Maybe I'll have them read a passage. Lots and lots of different speech contexts for that speech therapist to be taking really careful data and paying attention to how the movement of the mouth and oral structures is working across those different activities.
Evaluations for older children usually include a variety of different tests that are a mix of both standardized tests and more informal tests.
Evaluation for an older or more verbal child is going to be very in-depth. So when we're looking at a dynamic assessment for our kids who are those upper elementary, maybe even middle school, we're looking to see, okay, again, we're giving a single word articulation test. We just want to be able to analyze their vowels and their consonants, but we're also going to do dynamic motor speech assessment. We could give the DEMS to be able to see the simple syllable structures, and then we increase, because what we're trying to do is we're taxing their motor system. We're seeing how much information can they give us based on doing it spontaneously, or did we need to give them specific cueing? Did I need to tell them what to do with their movements in their mouth? How did they respond to it? Did they respond to giving them just a visual or a tactile cue?
We're going to most likely give a dynamic speech assessment, whether it's formally done in the context of the DEMS, or sometimes I will even just give an articulation assessment, so that way I can get the articulation scores, as well as have the children repeat the words a couple of times, so that way I can see for that consistency as well, and give a little bit of a dynamic assessment in the context of a speech assessment as well.
There will also be dynamic assessment because we are always wanting to see what happens when we provide cueing. This is also when we get to see if there is apraxia underlying, or if it might be something different, because taxing that motor system and making them work really hard and think a lot about how to produce a word either brings those characteristics to the forefront, or we don't see them and we know that this probably isn't apraxia. It could be severe phonological or something else.
The other things that we're looking at is through the dynamic assessment, it helps us to provide information on severity. We're looking to see what was their level of support that they needed in a test like that.
We're going to look at the phonology as well. And so when we're thinking about our speech sound disorders, we have our motor speech, but our motor speech, a lot of times as the speech is developing, goes into more phonological patterns. So we want to see what patterns are being used. If there's any other articulation pieces, so distortions of S or lisp or anything like that.
We may do other activities or assessment measures like a syllable repetition test. We're looking to see how do they take information into their brain? How do they encode it? How do they remember it? And how do they execute it?
You'll probably see what we call a challenging word task, where I'm going to give your child multisyllabic words to try and see what happens.
And then also an oral mechanism exam, looking at the child's their mouth, and a screener for nonverbal apraxia, where you're also looking at how they move their mouth for non-speech movements. There should also be a spontaneous speech and language sample to see what the child can do on their own. That might be done with play or with pictures, something like that.
Another thing that we're looking at too, again, is those connected speech samples. I think so many times we get focused on not just having a conversation with a child or showing them a picture and having them describe it, because we're listening for those prosodic errors, those vowel inconsistencies. Other things that are really important for children who are older is language testing. A lot of times we forget that it's what their speech errors are going to affect grammatical morphemes. So those verb endings, even sometimes processing information, word recall, all of these things that we want to keep assessing for and doing a thorough language assessment to see, because verbal speech affects language as well.
As far as the language goes, we're going to look at receptive language and expressive language. We want to make sure that that comprehension has continued to develop. One thing that I note with some of my kids is if their expressive language is stunted, especially my preschool age children, so not quite as old, but they're not able to then ask as many questions and get into things as far comprehension wise, because then their parents aren't explaining things. So I always want to make sure that that receptive language is moving along. We're going to look at that reading. So we're going to look at phonological awareness. What is the pre-literacy looking like? Our understanding of sounds and how they move together, as well as then going into our decoding and our writing. The literacy is a really big piece for our school age children.
I have to say that over the course of my time specializing in CAS, I've heard so many different answers to this question.
In our field, there's a misunderstanding of when a child can be diagnosed with apraxia.
There's not a gold standard age where you can say, well, at this age, we test for apraxia of speech, or we can confirm a diagnosis of apraxia of speech. It's whether or not your child can fully participate in a motor speech exam. So as long as they are able to imitate, are attempting imitation, can sit and attend to your face and look at you and follow cues and follow some basic directions, then they can participate in a motor speech exam.
The child needs to be demonstrating characteristics of CAS across speech tasks and be able to engage in a dynamic motor speech exam. So across speech tasks means that the child is able to say, imitate one syllable words, imitate two syllable words, name pictures, things like that. So it does require a decent amount of speech for the child to be able to complete those multiple speech tasks.
A child can be diagnosed with apraxia when they're demonstrating joint attention, when there's intent to communicate, as well as when the child is imitating.
The rule of thumb for diagnosing CAS effectively and appropriately is that a child needs to be able to engage in a certain amount of volitional, so intentional speech activities during the session, so that we can actually see what's happening when they try really hard to produce certain kinds of speech movement. If a child is able to engage in even just a little bit of intentional imitation, we can already start to see the kinds of things that that hit to us that there might be a challenge in their speech motor system. And so this might be for some children at age 3, this might be for some children at age 5, and for some children, it might be at age 19 or 20 months.
And the best way to diagnose is through a motor speech examination. So if a child can participate in that, it might be harder to diagnose under the age of 3, but it can be done.
The other thing that we really have to think about is that some characteristics of apraxia really need to be looked at carefully if the child's under the age of 3. So again, that's not all the characteristics, but some of our characteristics like vowel errors, voicing errors, inconsistency, difficulty with multisyllabic words. If the child's under the age of 3, those aren't necessarily characteristics of apraxia. So we just want to have extra caution if we're looking at diagnosing a child under the age of 3, but it certainly can be done.
One thing I will say is that for very young children, we have to be aware of the fact that the speech motor system is still in development itself. And so we don't want to make a hasty decision to diagnose childhood apraxia of speech before we give some time for overall developmental motor skills to come into play. And so at that point, if we're not sure, we see some maybe indications that apraxia might be present, we might opt to go with a suspected CAS diagnosis, and our treatment would proceed as if CAS was present until we could be sure that the diagnosis was confirmable.
Wow, that was a lot of helpful information about assessing and diagnosing children with apraxia. Thank you so much to all of our expert bootcamp graduates for giving us such great responses to commonly asked questions from parents and caregivers. If you are looking for more information about assessing and diagnosing children across different ages and skill levels, scan this QR code to check out our parent portal where you can read articles, watch webinars, and find lots more information specifically designed for families. Through our parent portal and videos like this, Apraxia Kids is giving hope by providing information and education to raise awareness about how a child is diagnosed with apraxia of speech. Thank you so much for watching.